What I'm going to do is just take you through a very interesting study that we undertook in South Africa a short while ago. And whether you look at it, you'll decide at the end whether it's a good news story or a bad news story, depending on whether you believe that the glass is half empty or half full. Just to give you some background, there are numerous surveys that have been undertaken throughout the world looking at whether patients on lipid-lowering therapy are achieving the goals which will establish that they get a reduction in their risk of atherosclerosis. And by and large, all these studies have been shown that hypercholesterolemia generally is very inadequately treated. But most of the data that we have, in fact, comes virtually exclusively from Europe or North America, United Kingdom, and there's really very little data, if not an absence of data, that reflects the status in developing nations, and there's virtually none that is ethnic specific. And even when you look at these studies, most of the data is predominantly for males. So here's a list of some of the surveys that you may or may not be familiar with in terms of looking at this, and you can see that they come predominantly from North America or Europe. And if you just look at the issue here, you'll see that women are relatively underrepresented in these studies. And if you go into ethnic differences where it is in fact even mentioned, you can see that really the information regarding to non-Caucasian groups is virtually absent. So with this in mind, we undertook the Cepheus South Africa Study, and the primary objective of the study was to look at the proportion of patients on lipid-lowering pharmacological therapy who were reaching the LDL goals as defined by either the North American, the NCEP ATP3 panel guidelines and the European guidelines, which were alluded to by Naomi in the first opening talk. So this was a multi-center survey undertaken throughout South Africa. We looked at consecutive patients who came in for a regularly scheduled visit, who were asked to participate and gave informed consent. Any gender, any ethnic group was eligible. They had to have been on lipid-lowering therapy for at least 3 months with no dosage adjustment for at least 6 weeks. And the time period of the study was between November 2009 and April 2010, and it was supported by a grant from AstraZeneca. We targeted 3,000 patients in predominantly urban areas in South Africa. We recruited just under that amount with full data sets. And to try and get a good spread amongst the different ethnic groups in South Africa, we targeted both the public and the private sector with a split of 2-to-1, and we achieved that in our patient population. We had a total of 101 investigators. We included primary healthcare practitioners, cardiologists, physicians, and endocrinologists. So we believe that we had quite a broad spectrum of the population. And what I'm going to show you now is stuff which has been presented at the Pan-African Society last year, as well as in the World Congress in Vancouver last year. And that is looking now at what are the how is the control of hyperlipidemia and what is the prevalence of risk factors in women, South African women, receiving lipid-lowering therapy. So firstly, just to take you through some of the demographics for the entire group, we had, as you said, 3,000 patients. Just under half were female. Average age was 59. Smokers about 15%. Family history 28%. BMI, certainly type 1 obesity, and very large waist circumferences. And now this is, again, not just specifically for women, but this is across the board for all the groups. You can see that there are substantial differences amongst the different ethnic groups. So, for example, as you would expect amongst patients of Asian ancestry, our Indian patients in South Africa, they've got a very high incidence of a family history because of it's been going for so long with the risk factors that they have. But our patients, African ancestry patients who are still in the stage of evolution in terms of risk factor development, haven't yet developed the family history. Similarly, smoking habits are a lot different across the different ethnic groups. But what I want to do is highlight, in fact, the results for women. So in terms of the total group, the splits you can see above, certainly women smoke a lot less than men. Family history is more or less equal. They are as overweight as are the men and have perhaps only marginally different waist circumferences compared to the men. But there are very interesting differences when we look at the demographics amongst the women of other ethnic origin. So I'll just highlight these. Firstly, we'll see that the mean age amongst our African women is actually the youngest, 57.4 years. And in fact, this ties in very well with the Interheart study and the Interheart Africa study, which was a worldwide study of risk factors for coronary artery disease. And in that study, women of sub-Saharan Africa were the youngest patients with coronary artery disease. So it in fact is reflected in the Cepheus study as well. You'll see that smoking has not yet become a major factor amongst our patients of African ancestry. Very few women smoke, and as I'm sure you'll realize, although it's not really portrayed in the study, but in terms of smoking consumption amongst patients of African ancestry, it tends to be rather minimal. They smoke a handful of cigarettes a day, whereas our Caucasian and Asian patients tend to smoke packets a day, not single cigarettes a day. You'll also note that patients of mixed ancestry, which were mostly from the Cape area, have got a very high smoking prevalence. Family history, as I alluded to previously, is still very low amongst African women, but very high amongst Asian women. But certainly as we are progressing in this evolution of urbanization of our African population, and as we'll show you just now, the burdening risk factors for cardiovascular disease that are occurring, this incidence of 11% of a family history is going to increase substantially in the next generation or two. Although all the patients were obese, our African females are amongst the most obese, really being severely obese with a BMI of 34%. I don't want to comment too much at the moment about the waist circumferences because there are different cutoffs for waist circumference depending on ethnicity. But whichever of those cutoffs you utilize, you can see that all our patients had the big boop syndrome. If we look specifically over here, we can see the BMIs. It shows up more in this cartoon over here. And again, you can see if we take a cutoff for type 1 obesity, only the Asian woman and the Caucasian woman just come in under type 1 obesity. But whereas the African women and the patients of mixed ancestry certainly fall severely into type 1 obesity. We've talked about the waist circumference, and there are ethnic differences, but again, whichever way you look at it, whereas the patients of African ancestry and Asian ancestry should have smaller waist circumferences than Caucasians, in South Africa we have it the reverse. So it really is a severe problem. The prevalence of hypertension. Now this is not the prevalence of hypertension in the population at large. This is a reflection of prevalence of hypertension in a population receiving lipid-lowering therapy. So please bear that in mind. But again, you can see that the prevalence of hypertension in our African patients is extremely high, as it is in patients of mixed ancestry, and the Caucasians tend to come in a bit lower, similar to the patients of Asian extraction. The prevalence of diabetes, very high amongst the African patients receiving lipid-lowering therapy, certainly compared to Caucasians. The other two population groups, by and large, are very similar. And obviously, if you mix all those factors together, the waist circumference, the BMI, the hypertension, the diabetes, you're going to have a huge prevalence of metabolic syndrome. And you can see that 88% of patients of African ancestry who are receiving lipid-lowering therapy have got features of the metabolic syndrome. It's certainly not a good news story as far as the Caucasians are concerned. More than 50% of them have metabolic syndrome. But you can see there are significant differences amongst the different groups. In terms of our diabetics, this is actually a very bad news slide. And it really shows that diabetics, particularly patients of African ancestry, are extremely poorly controlled. Now, please remember that this is a population of patients who have got access to health care. They were seeing doctors, they're on treatment for lipid. These are not patients without access to health care. So despite having the access to health care, if you look at their hemoglobin A1Cs reflected in the top here, very poor control of our patients of African ancestry. Even the patients of our Caucasian patients haven't certainly got very good control, whereas we're trying to aim for that to be below 6.5. So nobody achieved good control, but amongst our patients with African ancestry is extremely poor. And that's also reflected at the bottom in the fasting glucose levels. Again, you can see that patients of African ancestry have very high fasting glucose levels, indicating poor control of their diabetes mellitus. It's interesting to look at why patients were receiving lipid-lowering therapy, and if we divided them up into patients receiving it either for primary or secondary prevention, in other words, did they have manifest vascular disease or not, again, there are some differences. So the Caucasians are mostly getting lipid-lowering therapy for primary prevention, and the patients, African patients, very few of them are getting it for primary prevention. They're actually mostly getting it for secondary prevention reasons. And if we go into those secondary prevention reasons, you will see that in fact the vast majority of them are receiving it because of the presence of diabetes. So the diabetologists, the endocrinologists are doing a reasonably good job in terms of putting patients, the diabetic African patients at risk for coronary artery disease on lipid-lowering therapy. But again, it just reflects that the incidence and the spectrum of whether it's primary or secondary prevention differs. In this study, you'll also notice that the incidence of coronary artery disease was given as 14.3%, and that tallies in more or less with the figure which Karen has shown in the Heart of Soweto study, where it was also about 11-12%. So that's the current incidence of coronary artery disease amongst our black patients. But as you can see, with that sort of atherosclerotic milieu that is developing, this incidence is going to increase substantially over the next decade or so. So how well are we actually doing in comparison to other countries of the world? So here is a list of those studies that we showed you in the beginning. The only South African study that was previously in here was the South African Knotted Gold study, but that was predominantly Caucasian patients, and there it was a dismal 29% of patients achieving goal. If you look at the Cepheus South Africa study, it's actually not too bad. We're certainly on a par with other studies from Europe, and predominantly Europe and Canada, the HEDUZA study. The first NHANES study was 68%. They've improved to 78%, and they're now actually popping into the 80% with their most recent survey. So we're not doing too badly, or you could say we're doing as bad as the rest of the world. And if we look at goals in terms of North American guidelines, here we can say that patients of African ancestry are as well or as poorly treated as Caucasians. There's not too much difference in that. But our patients of mixed ancestry certainly are lagging far behind in terms of getting that goal. Now this is the results for all the patients. If we actually divide them up into male and female, you can see that across the board, women are not doing so well. Women are definitely doing a lot worse than their male counterparts, taking everything else into account. If we look at the European guidelines, which are the guidelines that we in South Africa adhere to, you can see the situation is a lot worse because of more stringent guidelines. So you can see that less patients are getting to goal, but the pattern remains the same. Patients of Caucasian patients and patients of African ancestry, more or less similar. Patients of mixed ancestry doing very poorly. And again, if we look at the male-female distribution, again, across the board, the women are doing far worse than the men. So there is certainly a lot of work that needs to be done. So in conclusion, we really can say that the management of hypercholesterolemia in South Africa, which is after all a developing nation, is comparable to other surveys from patients from countries which are developed nations. So we're not doing too badly in that regard. Control of hyperlipidemia in women of African ancestry is comparable to women of other ethnic groups, but it lags behind that in males of all ethnic groups. And generally, women of African ancestry receive lipid-lowering therapy due to the presence of diabetes mellitus rather than because of the presence of vascular disease. And also, women of African ancestry who are on lipid-lowering therapy have the highest prevalence of obesity, hypertension, diabetes, and obviously, consequently, the metabolic syndrome compared to women of other ethnic groups, and are younger than women of other ethnic groups. So they really are a sort of a time bomb heading for a place to explode. But at least with the Cepheus study now, for the first time, we've got some ethnic-specific data on patients who are receiving lipid-lowering therapy in a developing nation. So the take-home message is really not that this is a good news story, but that we actually have a long way to go to improving lipid care in our women patients. Thank you very much.